Welcome guys. In this video we are going to discuss about this Harrison based chapter 233, that is filarial and related infection. We are going to discuss under this following head. Alright, we are going to discuss about mainly lymphatic filariasis and tropical pulmonary eosinophilia, and we will discuss under the headings of epidemiology, pathology, clinical feature, diagnosis, treatment. We will also see Harrison based tables, images, and other important organisms which causes human diseases. Now, if you see that filarial worm, this filarial worm is a nematode that dwell in mainly in the lymphatic tissue or in the some cutaneous tissue in human body. Now, 8 filarial species has been identified with human disease, among which the notable one are Uchere bancrofti, Brugia malai, Onchocerca volva, and Lualua. These 4 causes big chunk of the disease in human. Now, in overall general view, if you can see that these are the vector-borne diseases, most of the vector being the mosquito, that is Culex, Anopheles, or Aedes. Now, of the Uchere bancrofti, which is also known for causing elephantiasis, which is the most famous one, and you see it is caused by Culex, Anopheles, as well as Aedes. Culex mosquito causes Wucheria in urban dwelling condition, whereas Anopheles Aedes cause in the rural region. Alright, now if you see the periodicity of the microfilaria, it is mainly nocturnal in most of the cases, whereas diurnal variation can be seen in Lualua, and subperiodic variation can be seen in Brugia malai. Alright, so in Lualua there is diurnal variation, in Brugia malai this is subperiodic, and most of the rest cases these are nocturnal in nature. Nocturnal, that is mainly seen in the night. Now if I talk about the epidemiology part, it has been widely distributed parasite of human, affect mainly in the tropics and subtropical region, including the Asia and the Pacific island region like Indonesia and Southeast Asian region, giving the main endemicity, and also the African region. Now this natural vector has been mosquito that I have already been discussed. Now if you see in India, the highly endemic region is this place, and mostly it resides in the coastal region. Alright, these are the highly endemic region for filariasis and filarial-borne diseases. Okay, so if I say about the pathology of how the disease process works, you can remember main pathological change that leads to the disease process is the inflammatory damage to lymphatics. Notable is that inflammatory damage to lymphatics is only caused by the adult worm. Why adult worm? Because adult worm is the one which resides in the lymph nodes or the lymphatic system. You can see against one in the chart that location of adult is in the lymphatics in most of the cases, except for Lualua and Onchocerca. So lymphatics, and these are the one which is responsible for pathogenesis. Now what do they do there? They can cause directly, they can affect directly, number 1. Number 2, due to the host immune response, there is a widespread host inflammatory response to this parasite, and which is believed to cause this granulomatous and proliferative process in the body. Cause granulomatous and a proliferative reaction in the body, which leads to granulomatous inflammation, ultimately leading to lymphatic obstruction and swelling. So Understanding this slide is very much important. So if we receive any patient who is having elephantiasis, swollen limb, like if I show the picture like this, alright. If you receive any patient with elephantiasis and swollen limb, it means that granulomatous inflammation has already blocked the lymphatic tract. That means the parasite is already dead in the person. There is no value of giving antiparasitic anymore in such patient, as the parasite is no more there. It has only happened when the parasite is dead. Alright. Okay. Okay. So how do they present? You know about the elephantiasis, but elephantiasis is the least presentation. There is no big clinical acumen to diagnose the elephantiasis or filariasis when elephantiasis has already set up, because you cannot help the patient very much. Your clinical skill lies to identify when this is the stage of subclinical stage. When there is no much elephantiasis, I can prevent the leaf. There is no much such edema. Alright. So what are the presentation? Presentation can be widely varied. So mostly organism resides in with infection reside in subclinical microfilaria stage. Alright. This is the stage which is the utmost important as a clinician, as if we can judge or if we can identify this stage, you can prevent later on progression to disease complication stage. Other, which is most commonly identified as subclinical microfilaria, is very difficult to identify even. Already, if I am unless someone is from the endemic region, family history of other having or family member having elephantiasis, you do the test of microfilaria and you got identification. There is no other way to identify subclinical microfilaria. So other stage which is easily identified and you need to screen is a patient presenting with hydrocele. Alright. Patient presenting with hydrocele, you can obviously go and test for microfilaria and identify that whether it is microfilaria filarial infection is present or not. Then is the thing in which the patient will come to you in the medicine ward. For hydrocele, it will go to the surgery. So subclinical patient will not come even. But in the medicine, patient will come with acute adenolymphangiosis. It is the stage when there is inflammatory response to the filarial parasite by the body, and patient lands up into the fever, raised DSR, and all the inflammatory changes. Alright, so they present with high grade fever, lymphangitis, lymphadenitis, and sometimes in the form of local edema. Alright, okay. Then you can get obviously chronic lymphatic diseases in the form of filariasis, that is nothing but elephantiasis. Alright, this is the easiest to identify, but no value of identification at that point of time. Alright, and also you can also get as a form of dermatolymphangioadenitis, which is often mistaken as cellulitis. So these are the usual 5 presentation of lymphatic filariasis. Alright, so what are the 5 presentation I am speaking about? The most common and easiest to identify is the elephantiasis part. Most common and the easiest identification is the elephantiasis part. Alright, the fourth one. In medicine, you need to identify this acute adenolymphangiosis case where the patient presents with high grade fever, lymphanginitis, lymphadenitis, and local edema. Alright, hydrocele, even if you no hydrocele cases should be missed just because you do operate and correct the hydrocele. It should not be kept in likewise. If you get a hydrocele, obviously check for the microfilaria level. Then look, if a patient coming to any surgical ward and hydrocele has been operated, but if you don't check the microfilariae, it will reside in the body. Again patient will end up into other complication in future. Alright. So obviously checking for microfilariae and treatment of filariasis is required if hydrocele is at all associated with filariasis. Now subclinical microfilaria, how do they present? Subclinical microfilaria presented microscopic hematuria, proteinuria, dilated lymphatics, and dilated lymphatics is only seen in ultrasound. And ultrasound of what? Ultrasound of the scrotal vessels, you will find dilated lymphatics. Alright, so if a patient of an endemic region, any urine routine examination comes to you which shows microscopic hematuria as well as proteinuria, you suspect subclinical microfilaria. How can you suspect? You can suspect based on the CBC report. If contains eosinophil percent is higher, obviously you can go for ultrasound scan for the scrotal region, or if a regional lymphatic is present, ultrasound of this regional lymph node to check for the dilated lymphatic. Sometimes the worm can be seen. Worm can be seen in the lymph channel which moves, which continuously moves, as well as you can order for microfilaria test. Alright. Okay. So presentation, hydrocele. Hydrocele is very much important as it is often grossly neglected and missed, because just because it has been caused with surgical causes, it can be due to the medical causes of filariasis too. Then this is the elephantiasis, that is. Alright. So this is the elephantiasis. Now, what are the changes you can see here? This is the change of the due to the lymphatic obstruction. So due to lymphatic damage, there is lymphatic damage. Why there is damage? Because adult worm invokes the host immune response which causes granulomatous inflammation and kills the worm, but worm remains in the lymphatic channel only. So it causes the damage of the lymphatic system and obstruction, which first will present into brownie edema. Alright, which first present into brownie edema. You can see this part, like this part, initial present of brownie edema. Then there will be hyperkeratosis, as you can see here. These are the places of hyperkeratosis. Then thickened subcutaneous tissues. For example, here in this part of the skin, you can see the thickened subcutaneous tissue, and then skin discoloration, shiny skin, as in this part. Shiny skin and skin discoloration can be seen. Alright, and obviously last but not the least, which is the most important, the known one, that is the advanced stage, which is also known as the elephantiasis. This is the last part of the foot. You can find the elephantiasis of the foot. So these are the skin changes which are seen. Alright. Okay. Now coming to the presentation once again, how do they present you? They can present you as subclinical microfilaria stage. They can present into hydrocele. It can present into chronic changes, as in this case of the elephantiasis. It can present into dermatolymphangioadenitis, which is often mistaken as cellulitis. Sometimes this patient with elephantiasis may come to you, because their skin has been changed, their lymphatic has been absolutely distracted, superficial nerve get disrupted, sensory system get distracted, so they catch up infection, secondary infection in the skin very easily, and secondary cellulitis or secondary skin infection might be there in case of elephantiasis. For example, this is a case that came to us. Around 60-year-old female came to us. 60-year-old female. She has such limb changes for around 10 to 12 years and non-diabetic. She was often grossly initially had pedal edema, which was in pitting variety and painful. So painful pitting edema, which was misdiagnosed as deep vein thrombosis. Unfortunately, ultrasound was not done and it was diagnosed clinically 10 years before, and she was on anticoagulant and whatnot else. But later on, when this elephantiasis and change was set up, it was found to be nothing but a case of a microfilariasis. All right. So she presented to us. With secondary skin infection. This is the elephantiasis sleeve, and these are the part which is secondary skin infection. These are the swollen red and tender in nature, and obviously secondary infection. We need to manage the secondary infection or cellulitis that is been set up. All right. She presented with high grade fever, raised TLC count, and around 15 to 16,000, and responded to antibiotic. Now, important to tell here from this case is that first she was mislabeled as deep vein thrombosis. Why mislabeled as deep vein thrombosis? Because she had bilateral pitting edema, which is tender in nature. All right. So, catch point of this discussion with filariasis is that you need to identify the disease early before the start of elephantiasis. Once elephantiasis has been set up, there is no value of doing any diagnosis, because you cannot reverse the change process. All right. Her limb was damaged. In this case, her limb was totally damaged, and we cannot reverse this. Only holistic approach and supporting approach can be applied on her case in such cases. All right. So this is the presentation of this. Now, coming to how we usually treat it. All right, and how to diagnose the stage of microfilaria. All right. Now, if I talk about the diagnosis part, definitive diagnosis is detection of parasite. Age detection of parasite is very, very tough, because how can you detect the parasite? You can detect the parasite either you take the biopsy of the tissue and directly observe in the microscope, or you do the Doppler scan, identify the organism. This is the only two ways in which you can identify. There is no other ways to definitely identify the organism. Okay, so definitive diagnosis is detection of parasite, but this is in practical sense not for useful value. All right. Now, how can you identify? So again, coming back to the chart, you see pathogenesis and everything was due to adult, but obviously you can identify the microfilaria because it is present in the blood. So blood investigation will help you identify the microfilarial antigen. Now, apart from the blood, where can we collect fluid from? We can collect from the fluid from the hydrocele, solent testis part, solent scrotal region part. We can collect the fluid and check for analysis for microfilaria. And what is the time of collection of blood? You can see there the nocturnal immunogen. That is, the parasite comes in the blood at the night time. So morning sample collection is no value. Usually it is preferred at 3 am sample or 4 am sample. Late night sample is preferred for detection of microfilaria. Okay, so definitive detection of parasite, there is no value. We cannot do this practically. So what is applied? It's applied is detection of microfilaria. Now, for microfilaria detection, you can go for either ELISA antibody detection or as well as rapid card test as a rapid card test. All right, rapid card test. From where you can collect the sample? You can collect the sample from blood. You can collect the sample from hydrocele fluid. Or you can collect from other bodily tissues. All right. Okay. Now, coming to the treatment part. Treatment part is obviously divided based on the symptom. How do they present? All right. Beside this microfilaria, other supportive investigation that will help is you will obviously get raised eosinophil. in differential leukocyte count as well as raise in serum IgE level. Okay. So raised in serum IgE level, raised in eosinophil, detection of microfilaria from blood gives you the diagnosis of filariasis. Now, once you diagnose the filariasis, how to treat the patient? Alright. So when you need to treat in the stage of the acute or active lymphatic filariasis. Now, what is active lymphatic filariasis? At the stage in which microfilaria is positive or antigen to the parasite, antigen to O. crafti is positive, or you can see adult 1 on USG Doppler. This is the active filariasis. In case of active filariasis, what are the medication you can go for? You can go for diethyl carbamazepine. And what is the diethyl carbamazine dose? Diethyl carbamazine dose is 6 mg per kg, and it is given once a dose days for total of duration of 12 days of minimum. Alright, 12 days minimum. You can also go for albendazole cover. Albendazole cover, it is 400 mg. Dose is TDS 3 times a day for 21 days. And it has been proven that 4 to 6 weeks of oral doxycycline, for 4 to 6 weeks is successful to reduce the microfilaria load. It is able to reduce the microfilaria load in both as well as the disease active stage as well in the chronic stage. Alright, okay. Now this is about active lymphatic filariasis stage, or as well as the treatment for subclinical microfilaria. For hydrocele, obviously nothing medical needs to be done. It is surgical management followed by you can give oral doxycycline for 4 to 6 weeks to reduce the load. Alright, now for lymphatic filariasis or elephantiasis, supportive therapy is only helpful. Alright, supportive therapy is only helpful. Now, beside this regimen, one thing that has been widely used all along as well as in India, and as in the African region, is ivermectin. Ivermectin has been widely used for the treatment of the lymphatic filariasis, and it has sustainable amount of microfilariacidal activity. Okay, so this is in short about lymphatic filariasis. Now coming to the next case. Now I will discuss about the case here. So this is a 16-year-old man. This is about a 16-year-old boy who was a resident of Bihar and farmer. He was a farmer, belonged to the farmer family who had not completed studies or into smoking habits along, presented with dry cough. And weight loss for 6 months. Alright, and weight loss was very apparent from the old pictures of the person. It has been evident he has lost around 20 to 30% of the body weight in last 6 months. Already. So when such patient came to us from poor region with a cough and weight loss, initial thought process comes to the mind is about the TB, to look for the chest pathology, and HRCT scan was done. HRCT scan, due to the reticulonodular opacities, and it was suggestive of hypersensitive pneumonitis. Okay, alright. TLC count was also reached around 27,000. When DLC was checked, the differential leukocyte was scanned. Surprisingly, eosinophil count was 70%. So this was a case of a tropical pulmonary eosinophilia. Alright, this was the case of tropical pulmonary eosinophilia. So to detect his cases, like bronchial valve lavage was done. As we did the microfilaria test, by the way, we did the microfilaria test was negative. We sent for IgG and IgM antibody for filaria specific, and at the meantime bronchial valve lavage was done to check for the any other infection, or whether it was a TB or not, or what causes this white lace and dry cough. Obviously bronchial valve lavage along with lung biopsy was done, and lung biopsy revealed endobronchial biopsy shows fragment of lung parenchyma which showing alveoli in places broken down with infiltrate of predominantly eosinophil. So it was eosinophil predominant, and eosinophilic microabscess formation was seen, which was suggestive of tropical pulmonary eosinophilia. All right. Okay. So what is tropical pulmonary eosinophilia? Tropical pulmonary okay. So main feature of tropical pulmonary eosinophilia, where the history, the patient particular comes important, is the residence part. Residence in endemic region. This is the first and foremost most important part of the history. Alright. Filaria endemic region, the present with paroxysmal come. What happens is that when this microfilaria in the blood is, most of them is cleared by the lungs. So when lungs clear them, goes for clearing this microfilaria, it raised into inflammatory reaction which causes the dry cough. Dry cough, sometimes dust sputum. Now when is the microfilaria seen? Microfilaria is seen in the late night in the blood. So it is getting cleared by the lungs in the late night. So paroxysm of cough at late night. Okay, so nocturnal cough, sometime wheeze can be seen. Wheeze just because of the allergic reaction. Okay, due to this allergic reaction, body's immune response, they do have a low grade fever, and nearest lymph node can be swollen. Nearer lymph nodes can be swollen, epidermity can be seen, and clinching point that help into diagnosis, in our case also, that was the 70 to 80% eosinophilia, that is mainly more than 3000 eosinophil in peripheral. Okay, more than 3000 eosinophil in the peripheral smear, and this is the reason how they might present you. Like, look, someone coming with dry cough and white loss, or cough and white loss, first thing that will come to the mind is obviously TB or malignancy. White loss with cough, malignancy. Now, with the history of endemic region, residence of endemic region, if you take detailed history of the cough, you will find that cough is always dry, usually dry, along with low grade fever at the night time, variegated and associated with breathlessness and wheezing sound at night. Okay, these are the clinging point, and obviously when you do the blood report, you will get eosinophil very much of high amount. This will help you in diagnosis. Alright. Okay. Along with what are the tests you need to do? IgE antibody, which will be present in this case, and antifilarial antibody, which will also be present. Alright. Blood microfilaria is usually negative. Why negative? Because if you see the pathogenesis of tropical pulmonary eosinophilia, it occurs only when lungs clear the microfilaria. So microfilaria level will be very much low or absent in case of tropical pulmonary eosinophilia. Alright. How do you treat them? You treat them with diethyl carbamazepine. What is the diethyl carbamazepine to be given? in case of filariasis, it was for 12 days, whereas in case of tropical pulmonary eosinophilia, you need to continue minimum for 2 weeks. This is the minimum. Sometimes more than 3 to 4 weeks dosage is also required, and symptom usually resolve within 3 to 7 days after the initiation of therapy, and although there is chance of relapse in around 12 to 25% of the cases. Alright, okay, and this relapse sometimes often occur after several years, like 4 to 5 years later. Okay, these are the most important diseases among this chapter, that is the tropical pulmonary eosinophilia and lymphatic filariasis. Now coming little bit of other diseases, let's discuss about the disease. It present with papular eruption as a consequence of onchocerciasis. So you can see these are the papular eruption which are itchy in nature. So onchocerca volvi, we are going to discuss about the onchocerca volvi. What we know already, that there is no periodicity in onchocerca volvi, mainly as other resides in lymphatic tissue, but onchocerca resides in subcutaneous tissue and microfilaria in skin and eye. Okay, and it is caused by the vector is black fly. So what are the important points you need to know about onchocerca? So this is caused by black fly, and the organism doesn't reside in the lymphatic, but it resides in the subcutaneous tissue. The adult reside in subcutaneous tissue. Common name of this onchocerca is river blindness. Why blindness? As it has association with infection of the eye, and from the word blind you can remember the black. So blind people says everything is black, so black fly causes the blindness. Alright, now it affects skin, eyes. So eye blindness, obviously eye involvement is there, subcutaneous tissue involvement, so there is skin involvement is there, as well as lymph node involvement there. Okay, now in contrast to the pathology in lymphatic filariasis, the damage in onchocercosis is elicited by microfilaria and not by the adult parasite, which causes the lymphatic obstruction in that cases. Alright, now in skin there is mild but chronic inflammatory changes in the form of papular eruption. Alright, in eye there is neovascularization and corneal scarring. Neovascularization and corneal scarring, which leads to corneal opacity and ultimately to the blindness. Alright, okay. Sometimes it can cause anterior uveitis, chorioretinitis. Snowflake cataract can also be seen. In another manifestation, important point for MCQ purpose, is dwarfism, typically due to the effect of the pituitary in onchocerca has been described, which is also known as Nakalanga dwarfism. Alright, okay, that's about onchocerca. And treatment involved doxycycline course of around 6 weeks. Doxycycline. Now what is this? This is a lua. And it is often identified. Now important part of lua, if you go to the Harrison table once again, it has got diurnal variation both night and daytime variation, and it is caused by deer flies. So D for diurnal, D for deer flies. Okay, D for diurnal, D for deer fly. It is seen in lua, and it is mainly adult stage in the subcutaneous tissues, microfilaria, and location is in the blood. Alright, okay. So this is the adult one. It is only identified when there is very difficult to identify. Only identified there is subconjunctival migration. When there is subconjunctival migration or formation of a swelling or angioedema, which is also known as calaver swelling. This calaver swelling are thought to be responsible due to the hypersensitivity reaction to the adult one. Alright, okay. Treatment involves diethyl carbamazine. Okay.